Hello friends, once again welcome to the Hospital and Clinical Pharmacy. Myself Miss Malvi Rajendra Bhavsar, M. Pharm in Pharmaceutics. So today we are going to start with the final and last part of Pathophysiology and Symptoms of Disease, that is part 3. After watching this, student will be able to learn Pathophysiology of diseases, etiology and sign and symptoms of that disease. Now, next disease we are going to study is epilepsy. It is a term used to define disorder characterized by recurrent, usually transient seizure, having sudden onset and spontaneous resolution. It is not a disease but rather a condition in which patients suffer from the complex sets of symptoms. Pathophysiology of epilepsy. Nerve impulse propagates in the brain in a synchronous pattern and electrical potential is close to zero. Any process which damages or irritates the grey matter of brain, it may result in activation or inactivation of neurons by unknown mechanism. This leads to sudden excessive synchronous electrical discharge, which result in electrical potential that remains localized. It results in partial seizure, or it may spread and involve the entire cerebrum, causing generalized seizure. Imbalance of excitatory transmitters such as gamma-aminobutyric acid, selective central nervous system, calcium channel blocker may involve in the disorders. Manifestation, that is sign and symptoms of epilepsy, differ with the types of epilepsy. So first is generalized seizure. It involves the entire cerebral cortex and this may be due to grand mal or petit mal type. In grand mal epilepsy, in this case, there is sudden loss of consciousness, falling, tonic and then clonic movements of muscles, incontinence of speeches. After this, patient may remain unconscious for long as 30 minutes. When the patient awakens, he has no recollection of the preceding event and he complains about headache. Second is petit mal, that is absence seizure. In this case, there is loss of consciousness for a few seconds. The patient may shows no facial expression and may blink eyelid or jerk thumb. Second is partial seizure. It involves localized convulsion of voluntary muscles, usually clonic in nature, generally lasts for only few minutes. The partial seizure activity may spread in orderly fashion to adjacent muscle group called Jacksonian seizure. Sometimes it may become generalized. The electroencephalogram is characteristically abnormal during a seizure but may be normal between the seizure. Next disease is diabetes. Diabetes mellitus is a chronic disease characterized by disorder in carbohydrate metabolism due to deficiency in action of insulin and possibly abnormally high amounts of glucagon and other insulin antagonist substance. In type 1 diabetes, there is absolute lack of insulin. The beta cells of pancreas decreases, causing reduction in insulin. In type 1 diabetes, there are no beta cells. Pathophysiology, lower levels of insulin result in overproduction of hepatic glucose and its underutilization. This results in hyperglycemia, and in presence of insulin, glucose enters into the cell, adipose tissue and muscle and is used up. Due to the lack of glucose, muscle cells carries out glycogenolysis and gluconeogenesis. Lack of glucose and insulin in adipose tissue causes impaired triglycerides synthesis and release of free fatty acids. These free fatty acids are metabolized in the liver to form ketones, and ketones supply to limited extent energy to muscles. Hyperglycemia results in glycosuria, that is glucose serum level exceeds the renal threshold for glucose reabsorption. Osmotic diuresis results in polyuria, polydipsia and dehydration. As glucose level rises, the glucoprotein is deposited in capillaries. Higher glucose is metabolized to sorbitol, which is responsible for the development of cataract and then neuropathy. The following equation illustrates how the blood glucose level is maintained with the normal limits by isolate of Langerhans of pancreas. Glucose is converted to glycogen by glucogenesis process or glucagon glycogenesis. Glucagon also stimulates the process of gluconeogenesis. The various actions of instinct are as follows. It increases the glucose uptake by muscle and fat. It inhibits gluconeogenesis. Conversion of glucose to glycogen and fatty acids are promoted. Conversion of fatty acid to triglyceride promotes and reverses the reaction, which is inhibited. Then there is a conversion of amino acid to protein promoted and reverses the reaction, inhibited. Normal fasting blood sugar level lies between 80 to 120 mg/%, whereas after rise to 150 mg/%. Due to the lower levels of insulin, there is mobilization of fatty acid leading to formation of a ketone bodies and acidosis, that is ketoacidosis. There is a hyperglycemia and glycosuria that result in dehydration. Now low level of insulin will result in increasing glycogenolysis. Gluconeogenesis also increases in the liver, which leads to increase in glucose, and result is osmotic diuresis or dehydration. Increased proteolysis in the muscle, which increase amino acid. Increased lipolysis in adipose tissue, which leads to increase in glycerol and increase in fatty acid. It increasing ketogenesis in liver, which is increased to butyrides and acetoacetate, which is result of in ketoacidosis. Signs and symptoms. Type 1 diabetes shows rapid onset and signs are polyuria, polyphagia, polydipsia, weakness, weight loss, decreased muscle strength and irritability. Type 2 diabetes is discovered only when sugar appears in the urine. Adult onset of diabetes may show weight loss, nocturia, blurred vision, anemia, neuropathy, vascular complication, etc. Ketoacidosis is a common type in type 1 diabetes. Other symptoms include tingling, numbness in feet, shows healing skin infection, itching and rawness. After a long time, diabetes often develop kidney failure, lesions of the eye, and atrophy of peripheral nerves. Diabetic patients are more prone to gangrene. These are the complications of diabetes mellitus. It may result to ketoacidosis, hyperglycemic hyperosmolar coma, retinopathy, neuropathy and nephropathy. Then peptic ulcer. Next disease is peptic ulcer. Ulceration is a loss of epithelial cell that lies in the digestive organs with extension of necrosis into underlying tissue. Peptic ulcer occur in the site where acid pepsin secretion is abundant. The two generally occurring forms of peptic ulcer are gastric ulcer and duodenal ulcer. Pathophysiology. Two main factors which involved in pathogenesis of peptic ulcer are acid and pepsin secretion and mucosal resistance to acid and pepsin. First is gastric ulcer. So the acid secretion is less than that of patient with a duodenal ulcer. Mucous membrane in the stomach of a patient with a gastric ulcer have less resistance than to those of other subject. Material refluxing from the duodenum damage the gastric mucosa. There is increase in bile acid in the stomach of a patient with a gastric ulcer as compared to a normal individual, but there is no direct evidence to support an idea that bile acid damages gastric mucous membrane. Ulceration takes place in any part of stomach. Signs and symptoms of gastric ulcer. Gastric pain which is reduced by food. The pain in gastric ulcer is also a burning pain but less localized than duodenal ulcer. Gastric ulcer pain generally does not occur at night. Complications include peritonitis, sepsis and pancreatitis. Duodenal ulcer. Secretion is stimulated by gastrin and cholinergic postganglionic vagal fibers. Patient have a higher acid secretion than normal individual or patient with gastric ulcer. This increased acid secretion may be due to increase in parietal cell mass or mass of a cell responsive to secretory stimuli. For unknown reason, the incidence of duodenal ulcer are higher in the cigarette smokers and in the patient with chronic renal failure and alcoholic cirrhosis. Ulceration usually take place on the anterior wall of first portion of duodenum. Signs and symptoms of duodenal ulcer. Duodenal ulcer disease is a chronic and recurrent. It begins with acute inflammation of duodenal mucosa and progress through more severe stage of duodenitis. There is a steady burning pain in mild epigastrium which relieves by the ingestion of food or antacid. The pain begins around 2 hours after meal. It may awaken the patient at around midnight, but pain is absent before breakfast. Patient gains weight due to eating to relieve pain. In some patient, there is no pain but shows hemorrhage. Sometimes there is a mild tenderness in the mid-epigastrium. Patient may show iron deficiency in anemia. Ulcer persists for 4 to 6 weeks. Complication of duodenal ulcer include peritonitis, sepsis and pancreatitis. Thank you friends. Thank you for your patience listening. Thank you very much.